switch gears now and move from diabetic retinopathy to macular degeneration. And I'm going to present two cases. We're going to start with a more routine case. So this was a 60-year-old American Indian female. She came in just for a AMD follow-up. She had no vision complaints, hadn't noticed any changes on AMSLR in her vision. She had been diagnosed with macular degeneration dry form 2 years ago, was taking AREDs only, hadn't had any other sort of ocular treatment like anti-VEGF. Her medical history, some prediabetes, high cholesterol. She was a former smoker. We know it's a risk factor for macular degeneration. And her best corrected visual acuities at this baseline visit was 20/25 minus in the right eye and slightly reduced 20/30 -1 in the left. And here we're looking at her color fundus photographs magnified on the macular region. And what I want to point out is that both eyes have these large-sized soft drusen. And large meaning greater than 125 microns. And you're like, well, I'm going to whoop out my measuring stick and see if that's 125 degrees. Just look at the width of a vein as it crosses the disc margin, and that's 125 microns, right? So this is much larger than that. So this is a large size drusen. You only need one large size drusen in order to put you into the intermediate stage of a non-exudative macular degeneration. So that's clearly what she has in both eyes, assuming no neovascularization is present. So the drusen centrally are usually, or we think are probably soft drusen because they have these indistinct borders. But then there's another subtype of drusen that we can see in this patient's color fundus photographs, which are these small, discrete kind of focal deposits in the perimacular region. And Dr. Parikh, would you mind commenting on what you think this other variant of drusen might be, and what is the clinical significance of that for you?
Yeah, no, excellent question. And as you sort of alluded to, they're very different in appearance, and they we'll use some other imaging modalities, of course, an OCT and maybe an autofluorescence, and we'll sort of use that to help differentiate drusen. Especially depending on what layer they're in. So these to me look like they could be, subretinal drusenoid deposits, also known as reticular drusen or pseudodrusen. And they tend to have a pretty poor prognosis. I mean, as do soft drusen, So I'm looking at this, Carolyn, and I'm not, this is sort of like, I'm not too happy about this. And, one of the interesting things you mentioned that I wanted to point out was, on your first slide, I think you said dry AMD, diagnosed with AMD 2 years ago. And, I see patients like this all the time, and it'll be like, oh, I just got diagnosed with AMD last week. And, the first thing I think is, listen, you've had AMD probably for years, Yeah. You probably had early, it doesn't just become intermediate all of a sudden. So anyway, I'll let you continue. But, I see this and I'm like, she's had AMD for years.
I couldn't agree more. I think that's an excellent point. I appreciate your insights there. And then I want to look at her raster OCT scans. And this is a raster in each eye, the right eye and the left eye, through the center of the macula. So we're seeing these soft drusen as large, round elevations of the RPE. But I also want to point out that other subvariant of drusen that we were seeing, which are subretinal drusenoid deposits. And I think a really good example is nasal here in the left eye, where we have this nodular hyperreflective deposit that's anterior to the RPE. So it's sitting on top of the RPE in the subretinal space. And of note, there's no signs of neovascularization or exudation here. And what would you be looking for, like fundus exam or OCT wise, that should scream at you exudation, Dr. Gleason, do you think?
Absolutely. So you want to be looking for any breaks in Bruch's membrane, any areas where neovascularization might be growing and kind of presenting itself through the retina, and any indication that there is subretinal fluid present, which may be a little bit difficult to tell if there's a lot of drusen kind of overlying those areas, kind of covering up the subretinal fluid. So that's where OCT is going to be very, very helpful in these cases.
Couldn't agree more. Yeah, looking for the drusen, the hemorrhage, exudate, pigment epithelial detachment, I think is all really important. So I've already alluded to the fact that, OCT we can use to classify different various subtypes of drusen, like hard, soft, or these reticular pseudodrusen or subretinal drusenoid deposits. And what I want to point out is that there's some research that suggests that subretinal drusenoid deposits are high-risk biomarkers for progression, as Dr. Parikh had already pointed out, not only for neovascular conversion, but also for conversion to atrophic advanced AMD, which is like central geographic atrophy. And this is just one study that showed that if you have a combination of soft drusen, which we typically think of as high risk, with these subretinal drusenoid deposits, that puts you at an even higher risk than if you had just soft drusen alone. So she's at one of the highest risks for conversion to neovascular AMD that we could possibly have based on the drusen subtypes present. I want to now fast forward. I'm so sorry, go ahead.
No, just one quick thing. While we're on the topic of the subretinal drusenoid deposits, I just wanted to highlight some interesting research that was presented at the ASRS, the American Society of Retina Specialists meeting just about a month ago on subretinal drusenoid deposits. And the team with Theodore Smith at Mount Sinai found a link between subretinal drusenoid deposits and cardiovascular disease that was pretty substantial. So they postulate that there may be a link between cardiovascular disease and the presence of subretinal drusenoid deposits, and sort of a very interesting area of research. And I know you're interested in the systemic diseases, and yes. I think this is a very important topic.
I love that you bring that up. I mean, I'm a firm believer that AMD is truly like a systemic disease. So I think that's an excellent point.
I agree.
If we fast forward now back to our patient 4 years into the future, we see that we've had drusen regression in both eyes. So the right eye, we have a little bit more pigmentary changes, which are another high risk biomarker for progression to advanced AMD. And the left eye looked like most of that drusen has gone away. And I think, back when I first had graduated or finished residency, I probably would have looked at it and said, oh, your AMD is improving, how wonderful. But then the more I, looked into this topic, drusen regression is actually a risk factor for progression to advanced AMD, especially the atrophic geographic atrophy form. And as we're seeing on her OCTs, that kind of helps confirm what's going on. In the left eye here at baseline, we had these large confluent soft drusen. At the 4-year follow-up, those drusen have collapsed, and we're starting to form what we call nascent geographic atrophy. And I like to think of this as like impending geographic atrophy, where we have a hypertransmission choroidal signal due to attenuation or loss of the RPE. And the outer plexiform layer seems to just be like sinking or kind of falling down into that pit. We know that this lesion is probably going to go on to develop full-blown geographic atrophy with complete atrophy of the photoreceptors and RPE. Some other high-risk biomarkers on OCT I want to point out that have formed in the right eye over the past 4 years. These hyperreflective foci, which are like these little hyperreflective deposits that often are on top of the apex of drusen, are also high risk for conversion to advanced AMD, as well as these hyperreflective columns, which are like these vertical bars of hypertransmission, telling you that the RPE on the apex of this drusen is compromised. So go ahead, I'm sorry.
I just wanted to ask you, when you're seeing these signs that indicate that it's a poor prognosis for your patient, how do you have these conversations with your patient? Because unlike a lot of the diseases that we manage, there's not a lot that we can do for our patients kind of earlier on in this disease phase other than watch them until they get worse. So how do you kind of navigate those conversations?
I think that's a great point. I mean, for me, usually patients at this stage aren't really symptomatic. So I always seem more concerned than they are, because I'm like, oh my gosh, I think you're going to convert. I need to watch you really closely like every 3 months. And they're like, I'm not really having any vision problems, but okay. So I think having that education about AREDS2, if they're not already taking, I would definitely recommend it at this point. Although I think there's little support to say it decreases the conversion to GA versus neovascular AMD. But then also just having an in-depth discussion, stop smoking, UV protection, nutritional, like dietary modification, is really important, I think, because we have nothing else that we can do right at this time, at least. Coming down the line, hopefully.
Absolutely.
And that conversation is going to continue in our later panel discussion.
Yeah, looking forward to that. So I want to point out that OCT angiography is really valuable in detecting early neovascularization, because it's going to allow you to directly visualize the membrane itself, not just the secondary exudative effects like fluid or whatever, actually looking at the membrane. So anytime I have a patient, like let's say this patient's right eye, where there's a large drusenoid, presumably drusenoid, pigment epithelial detachment, I'm going to position my segmentation lines on OCT angiography. So I'm sandwiching that PED. I want to see what's inside that PED sandwich. And is there neovascularization in there, right? So if I'm looking at my in-FOS image, neovascularization looks like a well-formed vascular net. I'm going to show you here in a minute. This patient just has atrophy of the choriocapillaries, which is a characteristic feature of atrophic macular degeneration. And just to put that in context and contrast it with a pigment epithelial detachment here that is vascularized. So there's a shallow, irregular pigment epithelial detachment. And on OCT angiography, we see this well-formed neovascular net, right? A very different presentation than this patient where it's truly drusenoid avascular versus this is a vascularized PED, definitely something I'm going to refer to Retina and get a second opinion on. This patient may benefit from anti-VEGF therapy. Let's now fast forward in time, one more time, at 5.5 years of follow-up. In the right eye, there's even more drusen regression, and we're starting to see multifocal geographic atrophy forming in the right eye, even centrally there. And then in the left eye, we have sort of frank geographic atrophy has formed centrally there, about 1/3 disc area in size. It seems bigger than previously. And on OCT, again, we have almost complete drusen regression in the central fovea of the right eye. And we now have nascent, impending geographic atrophy lesions where the retina is sinking down towards these areas of RPE atrophy with choroidal transmission defects as well. And then the left eye, this area of geographic atrophy seems to have enlarged compared to just 1 year ago. Fundus autofluorescence, I think, has a lot of value for two reasons in this case. One is looking at reticular pseudodrusen, which can be hard to see with just color fundus photography alone. And they look like dark hypoautofluorescent deposits on fundus autofluorescence, this kind of reticular pattern, really classic presentation of pseudodrusen. But then it also helps you delineate and monitor over time areas of geographic atrophy. When you have atrophy of the RPE, that's going to appear dark or hypoautofluorescent on FAF imaging. So we know that geographic atrophy is irreversible, unfortunately, and foveal involvement can actually occur probably faster than most of us think. When you think about geographic atrophy, at least me, you're like, oh, there's nothing to really do. It's like slowly progressing. But the fact of the matter is that it can be like 2.5 years from extrafoveal GA to when it actually involves the center of the fovea. Fortunately, there is hope on the horizon for these patients with geographic atrophy and nascent geographic atrophy. There are several pharma companies working mostly on complement inhibitors. Most of them are intravitreal injections. They're looking at an oral one I've also listed here that's under investigation. So there's really an exciting future, I think, to come for the treatment of geographic atrophy. And we need to prime ourselves now because I think the first drug is going to hit the market, at least in the US, that is, those of you who are attending or in the US, probably by the end of this year. And so we're going to identify these patients, start rounding them out now that have geographic atrophy, especially extrafoveal GA that may benefit from slowing the progression and helping to stabilize vision. Let's now switch gears and talk about the more extreme end and visually devastating, form of AMD, which is neovascular AMD. While only about 1/5 of AMD cases are exudative, neovascularization accounts for 90%, the majority of severe central vision loss from macular degeneration. So early detection by optometry, is really important by the patient if they can recognize the symptoms or on Amsler grid home screening, whatever that may be. Early detection is crucial. So you need to be looking on fundus examination for hemorrhage, for exudate, for the grayish green subretinal thickening. Right on OCT, you want to be looking for fluid, pigment epithelial detachment, especially if it's an irregular contour. It has a weird internal reflectivity. Or on OCT angiography, if you're seeing a frank choroidal neovascular membrane, that should all be concerning to you and you need to refer that out. The early retreat, the better the visual outcomes. I know, Sarah, you presented a case that kind of fell by the wayside because of COVID. I'm going to do a similar thing. So this was a 73-year-old American Indian female. She complained of decreased vision in the right eye for the past 6 months. She had a history of dry macular degeneration that we were following her for several years. She kind of missed 2 appointments, went off the wayside for about 15 months, and just showed up as a walk-in kind of in our emergency clinic. Her vision at this point was 2100. We had previously had her documented as 2020. So if we look at her color fundus photograph, we have this classic like grayish green subretinal thickening with an adjacent subretinal hemorrhage and retinal exudate, all features of exudative AMD. And then I'm going to show you several different raster scans, just structural OCT raster scans through her macula. So here in the center area of the macula, we have fluid at pretty much all levels possible. We have intraretinal fluid, we have subretinal fluid, and then we have this kind of irregular contour, multi-lobed pigment epithelial detachment that seems like it probably contains mostly fluid. Also want to point out this subretinal hyperreflective mass, which is the membrane itself that we're going to be able to visualize with OCT angiography here in a second. And look at this subretinal hyperreflective mass in the inferior macula. Again, this is the membrane itself exuding subretinal and intraretinal under the RPE fluid. Here on OCT angiography, this is the in-FOS image, and this is a 6 mm scan. So you can imagine how huge this choroidal neovascular membrane is. It's very mature. It has these like large feeder vessels associated with it. And then this is our B-scan overlay. So as Sarah mentioned earlier, the red aspect on top represents blood flow on top of your traditional structural OCT scans. So for that hyperreflective mass that we had with the structural imaging, it highlights in red, and that's the area of neovascularization that's kind of sandwiched between the RPE and the retina. And then these large feeder vessels here, we can see the lumens of those actually sitting in the subretinal space here.
Carolyn,
I think maybe that's something we can talk about in the panel discussion later with regards to like what changes would you expect in the OCT angiography morphology pattern with successful anti-VEGF treatment.
Carolyn, I was just going to say those last 2 slides, the images were amazing, where you can actually see that flow in the choroidal neovascular membrane. I think you look at a slide like this, and this sort of clinches your diagnosis. If this isn't one where you're like, oh, is this exudative? Is it not? You see this, and this is like, okay, you need treatment. So this is a beautiful slide.
I appreciate that. And for me, when I see like an eye here that's like so far gone, my immediate focus is to say, okay, even with treatment, this isn't going to change. I got to immediately change my focus to the fellow eye, do OCT angiography on that, a ton, make sure I can pick up the earliest neo possible in basically now what is a monocular patient.
Agreed. And, the earlier you treat, the better. So picking it up early on in the fellow eye is of utmost importance. I will say I have had some success in treating these patients, even when they come in as far gone as this, you reduce that fluid, and it's never going to take one injection. It's going to take multiple injections, and the patient has to sort of, they sort of understand that. And when it gets to this point, and like you said, does the vision ever, is it going to be 20/20 like she was before? No, but sometimes what you can do is you can really decrease the fluid. You can regress a little bit of that membrane, and even their central scotoma can get a little smaller. So I still treat these aggressively with anti-VEGF, and you do get some success, but like you're saying, this never goes back to like, a perfect eye, at least right now.
Yeah, I appreciate that insight. Yeah, I think she was 2100. What do you think if she had been compliant with anti-VEGF treatment, which unfortunately she wasn't, where do you think she could have gotten to vision-wise?
Yeah, it all depends on how early they're in, and then how good they are with the treatment in terms of follow-up. And also it depends how well they respond. It's interesting. We don't completely understand, but some patients respond a lot better than other patients to anti-VEGF. And then in some we're changing the anti-VEGF and we're decreasing the frequency of injections. But yeah, there's people that respond beautifully, and there's people that don't respond as well. And I think we still have to figure out why that's the case.
Yeah. Hopefully some longitudinal OCT angiography studies will identify like OCT angiography patterns that are going to respond best. to even perhaps certain medication. So in just the take-home summary of these two cases we presented, really important that you recognize OCT biomarkers that are high risk and predisposed to conversion from the intermediate non-exudative stage to advanced advanced AMD, whether that's central GA or neovascular AMD. Begin rounding up and looking for these patients with nascent, especially extrafoveal geographic atrophy that are going to be amenable to treatment that's coming out later this year, most likely. And then know the features of exudative AMD, literally like the back of your hand. You've got to recognize them. You've got to pick it up super early so that you can refer for immediate anti-VEGF therapy. And often OCT angiography really facilitates the earliest diagnosis of exudative or neovascular AMD possible. Any closing thoughts, guys?
Just wanted to comment on how fantastic your images are. It's a really great tool for you to manage these patients. And as we discussed with the previous case, to help educate your patients as well, if not to get treatment of the current eye you're imaging, but to hopefully monitor more frequently and be better compliant with their follow-up visits, their home monitoring of their vision, so you can preserve all vision possible in all of these patients.
Thank you.
Sarah and Caroline, those were, both of you did an amazing job. Those were amazing cases, and it really highlights the spectrum of pathology that we can see in dealing with these retinal conditions. So thank you both. This was fantastic.